Good afternoon, students. Today we will be taking up ocular trauma. This is an important topic from the point of view of your flying morals, and also you might get short notes from this section. We have two classes, so we will be taking this class about chemical injury and mechanical injuries of the eye, intraocular foreign body, retained intraocular foreign body, sympathetic ophthalmia, etc. will be taken up in the next class. So very broadly, we can divide or classify the trauma of the eye, as you can see, mechanical and non-mechanical. In the mechanical, we have extraocular foreign bodies, blunt trauma, perforating injuries, penetrating injuries, retained ocular foreign bodies, and sympathetic ophthalmitis. And in the non-mechanical classification, we have chemical burns, and chemical burns comprise of acid burns, alkali burns, thermal injuries, electrical injuries, and radiational injuries. UV radiation, infrared, and ionizing radiations, though albeit small, and a general ophthalmologist may hardly get one in his career, but it is important to take a note of it. Now, chemical injury. Chemical injury is one injury or one such condition in the entire gamut of medical profession where you have to manage first and then take a history. So I'll come to that later. Broadly speaking, again, chemical injury can be divided into two broad subspecifications. They are acid burns and alkali burns. Now, grading of the chemical burns. This is very important. This gives an offhand assessment ability to the clinician regarding the severity of the chemical burn that has taken place, and it can also give you a very rough idea of the prognosis, the visual prognosis of the patient. So, grade 1 is mild or there is no limbal ischemia. Grade 2 is moderate, that is less than 180 degrees of limbal ischemia with epithelial defects, but the cornea is still clear and you can see the details of the anterior chamber. Grade 3 is severe and it is more than 180 degree or half of the limbus. So limbal ischemia more than 180 degree with epithelial defects and a hazy cornea. And grade 4, this is severe. This is more than 270, that is more than 3/4 of the total 360 degree of the limbus, and there is epithelial defects, hazy, and you might not be able, hazy cornea, and you might not be able to make out any details of the anterior chamber. Now, how do you assess limbal ischemia? Now, limbal ischemia is assessed by looking at the limbal vessels. So, if there are limbal vessels which you can see and they look healthy to you, which means that they are healthy. But in case of limbal ischemia, the limbal vessels are obliterated. You won't find any limbal vessels there, and the limbal and that area will appear to be white or burnt, as the case may be. Now, coming to the subgroup of chemical burn, alkali burns. Now, alkali burns are much more severe than acid burns. And as we all know, when an acid burns a tissue, it forms a very thick leathery eschar. That is, the proteins are coagulated, and this itself prevents the further penetration of the acids, and hence there is a natural tendency of the acid burn to be self-limited after a certain level. So this happens more in cases of the common bathroom cleaner or muriatic acid or hydrochloric acid, but in cases of hydrofluoric acid or in cases of concentrated nitric acid, this effect of eschar formation is not seen because they are very powerful acids and they do cause meltdown of the cornea very fast. In alkali, on the other hand, what happens is the alkali, they just saponify, that is, they form soap solutions, after they burn with the proteins, and the saponification results in meltdown. So there is no barrier formation as with acids, no eschar is seen, and as long as there is active ingredient or active alkali present, they will keep on melting and penetrating deeper. So this is much more dangerous and it causes widespread damage to the structures of the eye. Now, common agents which we find are ammonia, lime, lye, sometimes even magnesium hydrochloride, hydroxide, And among this, the commonest ammonia commonest being ammonia. Why? Because ammonia is a solution which is usually found in drain cleaners. So this is used in household drain cleaning or cleaning of the sinks, wash basins, and hence the propensity to cause accidents and spilling into the eye is also much more. Next comes the lime. The lime is used in whitewashing very widely in our country. Also, when cement is being mixed with water, so sometimes, because this is an exothermic reaction, there is an explosion and it causes a tendency for this lime to splash into the eye. The common acids that we see are, as I was telling you, the bathroom cleaners or hydrochloric or muriatic acids, followed by sulfuric acid, and then obviously nitric acid and hydrofluoric acid. So hydrofluoric acid burns and injuries are seen in glass etchers, because this is a compound which is used in etching designs on glass. So it is a very potent acid. It can even dissolve glass. So you can imagine what it can do to the cornea. The next in the severity list is concentrated nitric acid. This is or aqua regia. This is used in the goldsmith shops, or the gold by the goldsmiths. So this is also a very powerful and potent acid, and it causes a complete meltdown if it splashes on your cornea. Sulfuric acid usually is seen in car mechanic shops where the battery solution is sulfuric acid, but since it is to an extent dilute and not concentrated, so this splash causes a limited damage to the eye, especially if it is quickly and completely washed. And the least in the severity, but mind you, least in the severity of the list, it by itself is quite severe, is the bathroom cleaners or the muriatic acid. So if by chance there is a splash, the first thing that a person has to do, the first aid, is wash, wash and wash. Now we'll go to emergency management of the chemical injuries. And as I was telling you in the previous slide, this is one injury where you have to treat first and then take a history. Meaning, first you have to secure airway, breathing and circulation, that is the ABCs, as with all other injuries, and then you have to start irrigation. Now this irrigation can be anything, so whatever comes handy. By meaning anything, tap water is fine. So if at the site of the injury nothing else is available, you must wash it at least for 5 to 10 minutes by copiously by irrigating the eye with tap water. Obviously, once the patient is in the emergency, we use ringer lactate. And how much is a sufficient wash? Now it is said that you have to wash the eye for at least half an hour. So roughly what we do is 3 to 5 bottles of ringer lactate are usually used to wash the eye. Now why so much of a solution is used? This is particularly true in case of alkali burns. In alkali burns, what we have is the particles of the cement or the lime or pellets of magnesium hydroxide, etc. They tend to get lodged into the tarsal sulcus or into the fornix. So as long as these agents are present in the eye, they will continue to elute alkali and continue to cause damage. So we must get rid of each and every particle that we at least see. And there are small particles which are not available or not seen to the naked eye, and it is for this that a complete copious washing or irrigation is required. The next is a cycloplegic. Naturally, an eye which is challenged by a chemical burn will be an irritated eye, and you have to rest the ciliary body. That will also lessen the pain to some extent. So cycloplegic is important. Next is topical steroids. Now topical steroids is something which appears to be confusing, because this is something which has to be given, so there is a limitation of inflammation, and it is used very judiciously and very carefully, because in the initial phase we do not want a lot of reaction to happen, but in the later phase we do want some repair to happen. So this is a steroid this is a medication, a steroid which is topically given for say about 7 days, after which the eye will need to be tectonically sound, otherwise a meltdown might occur. So we stop the use of steroid after 7 days, but initially a steroid has to be given, or else we might see unsightly scars. Oral tetracycline. Now oral tetracycline in the shape of doxycycline or minocycline has to be given. They limit scar formation, and they also promote, like vitamin C, they promote the formation or the repair of the burnt cornea. Now topical antibiotic ointment, without any doubt we have to give, so that secondary infections do not occur. In this aspect, let me tell you that it is important you give a 4th generation fluoroquinolone topically, because they are the ones which have the least effect or toxic effect on the cornea or the healing of the cornea. So moxifloxacin or a gatifloxacin would be nice. Then obviously we will give oral analgesic to do away with the pain. Acetazolamide can be given in both topical as well as in the form of systemic, because obviously topical acetazolamide is not there. We would give brinzolamide for that matter. And it is important because initially it is seen that whenever there is a burn, whether it is an alkali burn or an acid burn, there is a tendency of distortion of the trabecular meshwork, resulting in an acute increase in the intraocular pressure. So this has deleterious effect on healing of the cornea, and hence we must give something to relieve the intraocular pressure, and we give systemic acetazolamide. Added to this, you can also give topical anti-glaucoma drugs and preservative free tear substitute. Obviously, for more hydroxylation as well as better cornea repair, we could give an ascorbic acid. Ascorbic acid or vitamin C is given at the dose of 1 gram per day in such patients. Now this is important, amniotic membrane transplantation. Now amongst the newer modalities of treatment, amniotic membrane transplantation occurs a pride of place. It is given in acute chemical burns, and it acts as a bandage contact lens, as well as it acts to heal the cornea in a better way. So there are two aspects to it. So it helps to maintain the clonicity or the clonogenicity of the limbal stem cells, so they can better function and in the repair of the cornea, as well as it sort of forms a biological scaffolding for the corneal epithelium to regrow. And others such as bandage contact lenses or cyanoacrylate glue might be given. Bandage contact lens because the eye is irritable, and it causes a lot of foreign body sensation, so this is relieved to a great extent by bandage contact lenses, as well as there is a tendency of symblepharon formation in these eyes, so it would be a good idea to have a bandage contact lens there, and cyanoacrylate glue if there is perforation. Now, before we move on to the mechanical injuries caused to the eyeball, there are certain important terminologies which one should be aware of. So, from the point of view of describe a mechanical injury of the eyeball is constituted of the sclera and the cornea. These are the two coats which we consider. Now, what is a closed globe injury? A closed globe injury is a non-full thickness wound of the eye. An open globe injury is a full thickness wound of the eye. Now, open globe injury could be a penetrating injury, or it could be a perforating injury. A penetrating injury would be there is only one wound, that is the entrance wound, and a perforating injury is there are two wounds, one an entry wound and one an exit wound. Now, what is a contusion? Contusion is injury is due to the direct blunt trauma or change in the shape of the globe. What is a rupture? Rupture is a full thickness wound of the eyeball caused by a blunt object. What is laceration? It is also a full thickness wound of the eyeball wall, but it is caused by a sharp object. So please bear in mind and refer to the slide if you need. Now, this is an ocular trauma scale. Obviously, the ocular trauma score is important, but it's important for advanced students. We will discuss it if we get time later. Now, blunt trauma. A trauma caused by a blunt object trauma to the eye ball, that is the blunt trauma. It could be anything. It could be a punch in the eye, it could be an injury by a ball, or it could be any other injuries caused by other objects. Now, what are the mechanical injuries that we see? So it could be conjunctival laceration. Now, one very favorite question which the examiner asks in the viva is, it goes like this: suppose somebody hits you with a fist on your eye. So what are the injuries from without inwards that you expect to see in the eye? So this is a question which will test your knowledge about the entire gamut of mechanical injuries that the eye can suffer. So we will take that question and we will describe from without inwards one after the other. So conjunctival laceration, then you could have a subconjunctival hemorrhage, you could have a sclerocorneal rupture, you could have Descemet's folds, you can have hyphema, you can have traumatic iridodialysis, you could have a Vosseus ring, and you could have a lens dislocation or subluxation. So these are all in the anterior chamber. Traumatic cataract. Then in the posterior chamber, you could have a vitreous hemorrhage, you could have a traumatic retinal dialysis, you could have intraretinal hemorrhage, choroidal rupture, traumatic retinal detachment, and a blowout fracture of the orbit. So these are all the injuries that a person can suffer when he is landed with a trauma by a fist, or say with a ball, or with some heavy object to his eye. Now there are certain late effects which can happen, that is angle recession. Traumatic cataracts, of course, doesn't happen in a day. Traumatic macular hole takes about a week to 6 weeks. Traumatic optic neuritis, and auto evisceration and traumatic enucleation. Well, auto evisceration and traumatic enucleation is also not late effect. It can happen immediately after the injury, especially in road traffic accidents or high velocity injuries. Now, as you can see, this is a picture of a figure which is showing a conjunctival laceration. So in conjunctival laceration, what happens is a blunt trauma which grazes the eyeball, and in its wake it leaves, a sort of a ruptured or a lacerated conjunctiva. And in this you will have the typical feature is you will have some amount of subconjunctival hemorrhage, which I'll tell you in the next slide, and you will have a non-regular or abraded surface of the conjunctiva. Now this is a photograph which shows subconjunctival hemorrhage. Now subconjunctival hemorrhage usually happens due to the laceration or the rupture of small blood vessels that are traversing just below the conjunctiva, or they are the episcleral vessels. So when they rupture or when they are damaged, the blood collects below the conjunctiva, and you see a picture like this. Now this appears to be very very severe, but in usually it is something which is not so severe, and it goes away by 10 to 14 days. The patient needs to be reassured. Sclerocorneal rupture. Now sclerocorneal rupture, the weakest part of the eyeball which involves a sclerocorneal rupture is basically the limbus. So along the limbus there is a sclerocorneal rupture, and the next the weak part in the eyeball is where the intraocular muscles are inserted. So as you know, the thickness of the sclera out there is almost half of the thickness elsewhere. So these are the areas which, when challenged with an increase in IOP, sudden increase in IOP due to a trauma, give away, and because they give way, these are the areas which suffer laceration. Here in the picture you can see that there is a sclerocorneal rupture, and through this rupture a part of the iris has come out, and the part of the iris is incarcerated in the wound. So a typical management of this case would be, you will depends on the time when the patient presents to you. If he presents immediately, then obviously after copious irrigation of the iris, you can you can replace the iris inside, and you can sew the wound up with sutures, 10-0 nylon sutures. But if the iris has or the eye has been presented to you after say 24 hours, it would be best to abscise the iris, cut away the iris which is outside of the wound, and then repose the rest of the tissue inside with a visco elastic substance, and sew the wound so that you get a watertight cornea. Now, hyphema. What is hyphema? Hyphema is basically a presence of blood in the anterior chamber. Now, we can roughly classify hyphema into microhyphema, or in microhyphema, you do not have any level of blood in the anterior chamber. The amount of bleeding is far too less than the blood to accumulate. Only a few red blood corpuscles are there, and they circulate in the anterior chamber, and as a result of which they give a certain vague, foggy appearance to the aqueous, and under slit lamp illumination you might be able to see what is known as cells. Now, grade 1 hyphema is less than 1/3 the anterior chamber volume. Grade 2 is between 1/3 and half of the anterior chamber volume, and grade 3 is more than half of the anterior chamber volume. Grade 4 is a total anterior chamber 8-ball hyphema. Now, what is this 8-ball hyphema? So 8 ball is basically the black ball in the game of billiards. So the eye just resembles like a shiny black ball, especially the anterior chamber, and hence it is known as the 8-ball or the grade 4 hyphema. So these are certain pictures of hyphema. The first one obviously is a grade 2 hyphema, or a grade 1 hyphema rather. So it is less than 1/3. The second one is almost full. So is the third one. So the third one will be your what is known as a black ball, yeah, it's known as the 8-ball hyphema. So it's a total hyphema, grade 4. How to treat and when to admit. So what is important here is, if you see a hyphema which is more than a microscopic hyphema, so it could be a grade 1 hyphema through grade 4 hyphema, anything, if it's a child, he needs to be admitted. Now, how do you treat? So protective shield has to be given to that eye, so the person doesn't rub his eye and induce more bleeding into the anterior chamber. Patient has to be rested. Now, bed rest is necessary for hyphema to settle down, but obviously the head end of the bed has to be elevated. Maybe a couple of pillows will do, and the person is allowed to get up for his ablutions. He can go to the toilet, but that is all. The rest of the day he has to be bed bound, and strict bed rest is ordered. Now, relieve the discomfort of inflammation. So cycloplegics has to be given. Now, there are some authorities who say that atropine must not be given, must be avoided, because atropine itself induces more bleeding. So we prefer at NRS to give homatropine. And topical corticosteroids has to be given because they can be associated with inflammation of the anterior chamber, so it needs to be given. Beta blockers are given, and topical carbonic acid anhydrase inhibitors are to be given. Now, beta blockers and CAIs are required because obviously it would be a secondary glaucoma which is induced because of the blocking of the trabecular meshwork by the RBCs. So there is a tendency in these eyes to have a raised IOP that has to be addressed by topical beta blockers as well as topical beta blockers as well as topical CAIs. Now, if the patient is unwell, if the patient complains of pain, if the patient has nausea, vomiting, which means that there is a significant rise in IOP, he has to be treated with a systemic agent like a hyperosmotic agents like mannitol. and secondary bleed has to be managed. So there are patients who have bleeding diathesis, so they have to be, the primary reason of their bleeding has to be managed alongside. So obviously you could give a tranexamic acid or a lysine analog. Now, so when do we admit the patient? 4 days have passed in case of total hyphema. Microscopy blood stain of the cornea anytime. Total hyphema, IOP more than 50 millimeter Hg or more for 4 days. Grade 3 or 4 with pressure more than 25 millimeter of mercury for more than 6 days. More than 50% for more than 8 to 9 days. And in sickle cell patients who have more than 35 millimeter of mercury IOP for more than 24 hours. Now this is the protocol which we follow for draining the hyphema. So hyphema is managed conservatively, as you saw in the previous slide, but these are the few conditions in which we give up or we take up the additional procedure of relieving the hyphema or draining the hyphema. So because it might cause microscopic blood stain of the cornea, and once the cornea is stained, the patient loses significant visual power as a result of, and the clearing of cornea also takes a long time. I'll just give you a hint. So a person who is having a blood stain, microscopic blood stain of cornea, requires almost 2 years for the cornea to turn white, provided everything else in his eye is healthy. Now this is a traumatic iridodialysis. As you can see that there was a blunt trauma to the eye, and this has caused the root of the iris to tear. And as you can see, the pupil has become D-shaped. It is shaped like the letter D, and there are basically almost now 2 pupil, so to say. So these patients also suffer apart from hyphema because the blood comes out from the torn root of the iris, which of course in this photograph has cleared, but they suffer from hyphema. They can suffer from increased IOP, that is a secondary glaucoma, and most importantly they have uniocular diplopia, because now there are 2 orifices or the 2 pupils which are letting in light. Now Vossius ring. Now what is a Vossius ring? Vossius ring is basically an imprint of the iris pigments on the anterior capsule of the lens. This happens when there is a trauma to the eye, and such is the trauma that the cornea goes all the way, or the cornea is displaced all the way so as to touch the iris and the lens. So such is the force. So the cornea is totally deformed, and it goes and hits the anterior capsule or hits the lens, and as a result of which the imprint of the iris pigments is left back on the anterior capsule, as you can see. Now lens dislocation. Now there is something which must be told about dislocation and subluxation. So subluxation is basically displacement of a organ, or so to speak, but a part of which still remains within the anatomical position. That is subluxation. And dislocation is when the organ or when the part is totally displaced and no part of it remains within the anatomical position or natural anatomical position of the organ. So that is dislocation. And the other one in which a part of it remains in the anatomical position is known as subluxation. So here, as you can see, the lens has completely come into the anterior chamber. That is not its anatomical position. So this is a dislocation, anterior dislocation of the lens. Now in the photograph on the right, you can see that the lens has fallen down over the optic nerve head, and this obviously is a dislocation. And the second one is also an anterior dislocation, as you can see. So there are 2 anterior dislocations in the picture, and 1 posterior dislocation of the lens into the vitreous cavity, and the lens is lying comfortably over the optic nerve head. Now this is a subluxation. In this, a part of the lens still remains in the patellar fossa, and part of the lens is displaced due to rupture of the zonules, especially on the superior side. So that is the superomedial side. The lens, the zonules have disrupted, resulting in the intact zonules pulling the lens inferiorly and inferiorly and laterally. Now these are traumatic cataracts. The picture on the left is beautiful. You have rosette cataract, which is typically associated with trauma. So this is a rosette cataract which has developed a few days after the eye underwent a trauma. And the other picture also shows, but this is more or less maybe the way it is, it's a mature cataract in which there is, you know, total opacification of the lens. It appears that there must have been a rupture of the lens capsule. The rupture of lens capsule is associated with the hydration of the lens, and it results in such a opacification. It's a pillowy, feathery opacification, and it is a mature cataract. This has to be removed. Now vitreous hemorrhage can occur due to a severe, really severe blow to the eye, and it could be one of the larger vessels which might have ruptured due to the disfigurement or of the eyeball due to the trauma. So here's a picture which shows vitreous hemorrhage. Now this is a retinal dialysis. As you can see, it's a large tear in the periphery of the retina, and this is more than, say, 2 or 3 clock hours. So this can happen. This usually happens near the base of the retina, where the retina is very firmly attached near the ora serrata, and this is relatively inflexible part of the retina. And when the eye is subjected to a trauma and it undergoes a disfigurement, it is here that there is a shearing force which appears on the retina, and the retina is, you know, torn. So a part of it intact under the firm adhesion of the ora serrata, and the part which is relatively loosely attached gets torn away. So this is a picture of a retinal dialysis. Now there is a choroidal rupture. Choroidal ruptures occur when the choroidal tissue, they suffer break. Now they have a typical appearance, and we ophthalmologists can immediately diagnose one, because they have their concavity facing towards the optic nerve head, and there might be 2 or 3 such concentric concavities if the blow is really hard. And in this case we are finding 2 such choroidal ruptures, as you can see, one near and inferior to the optic nerve head, and the other a little farther and almost running through the macula. Traumatic RD can happen, but usually what we see is traumatic RDs are usually detected after, say, 7 days after the surgery, after the this thing trauma. So this is a typical picture that you have seen. The management of the traumatic, or the rather management of all the posterior segment mechanical injuries, will be covered in hopefully in the next lecture. Now, traumatic evisceration and enucleation, these are usually injuries which are associated with road traffic accidents. They are associated with high velocity injury, with gunshots, and sometimes even animal attacks. So here in NRS we find a lot of animal attacks, patients which are referred from the infectious disease hospital at Beleghata. So these are dog bite injuries. Now they are typically and tragically associated with children, because little children who are 3-4 years old, they usually are tall enough to be at the height of the dog's mouth. So playfully, sometimes when the children tease the dogs, they attack, and the point of attack is usually the face or the eye. So they end up biting out the eye, and there is a traumatic enucleation. The entire eye is, and the entire eye of the child is just torn out by the vicious attack of the dog. So we do get such cases in which obviously the eye is lost, and sometimes you also get evisceration, in which the dog could not manage and could only lacerate the globe, so the contents of the globe come out. So that is an auto evisceration. These are also seen, as we have seen in certain, bicycle injury. The brake lever of the handle of the bicycle gets into the eye, and as the person falls, so it just scoops out the eyeball. So you have such kind of a injury. Even gunshot injuries in which the exit wound is from the eye, or the entry wound is from the eye, will totally shatter the eye, resulting in an evisceration. Now the last of today's topic, the blowout fracture of the orbit. Now blowout fracture of the orbit is by itself a short note, in which what happens is when a fist lands on the eye, such that the size of the agent which is inflicting the trauma is larger than the size of the globe of the eye, it causes the compression of the globe. And once it causes the compression of the globe, the orbit, being a rigid place, will try to find a way out to dissipate the compression. Now the area which is the weakest in the orbit usually gives way, and through this the compressing force is relieved, and this results in a blowout fracture. So which is the weakest? It is usually the floor, followed by the medial wall of the orbit. So we have a fracture of the floor, or the maxillary roof, so to speak, and contents, extraocular contents or orbital contents, are driven into it. So this results in a blowout fracture, as you can see in the picture. Now this is a young girl who had fallen down from the roof of a first floor building, of a one-storied building, and this was treated here at NRS. I had treated this patient. So as you can see, the patient had presented after 7 days. She was there in Murshidabad Medical College, and from there she was referred to us. Now this patient was having a diplopia, so, and a little bit of enophthalmos. So if you can see the picture at the left, you will see that her right eye is comparatively larger than her left eye. Why is it so? Because the left eye is a little enophthalmic, because a lot of the orbital contents are already inside the fracture of the roof of the orbit. So through that, it has herniated into the maxillary antrum, as a result of which there is a loss of volume in the orbit, as a result of which the eye has become enophthalmic. Now what are we trying to do in the second picture? In the second picture we are trying to see the ocular movements, and we see that the ocular movements, so she is moving her eyes well to the right side, and in the picture below what we see is she is looking down. So there is an depression of the eye in the right eye. The right eye is the normal eye, but there is no depression of the eye in the left eye. So this patient basically had a double diplopia. So she would be having diplopia when she looked up, and she would be having diplopia when she looked down, because both her depression as well as elevation of the left eye was restricted. This had to be relieved, and this was a case which was fit to undergo reduction of the orbital floor fracture. Now you see, this is intraoperative photographs of the same patients, and these are showing the black triangle which you are seeing is basically the fracture. So that is the fracture, and that black hole that you are seeing in the picture is basically a communication from the orbit to the maxillary antrum. What we are trying to do is, and we have done also, that we have gently lifted out all the orbital contents from the which had herniated into the opening, or into the fracture, and in that part we had put usually what we do is we put a titanium plate, but in this case, since she was a child and there was a chance of a orbit to grow further as the facial skeleton grows till 14 years of age, so we decided that we would use some material which was biointegral. So we used a hydroxyapatite patch, which is also known commercially as an os patch, and we did that. So we just put the os patch over the defect that you can see, and then we laid back the contents, and we covered the wound in layers. So now if you see at the rightmost picture, you will see that the patient is showing some amount of I mean, echoes just below her eyeball, and that is the os patch which is there. And after 1 year, so this was done 2 or 3 years back. So after 1 year, when the patient had come last year, so we found that we did a MRI again, and we found that there was a very nice biointegration, and we could not even make out the os patch. In fact, such was the integration. Blood vessels had grown into the os patch, and she was doing fine. But unfortunately, she still has restriction of elevation, and this is because she was presented to us later, and not immediately. So by that time, there was some amount of atrophy of the superior rectus. So superior rectus function was lost. Otherwise, she had good depression and all other ocular movements. Also, her enophthalmos was cured. So that almost we come to the end of today's lecture. So the posterior segment injuries and the treatment of all that I said today will be taken up in the next class. Thank you.